Yes. Okay. Hello, dear colleagues. Hello. How are you? My name is Berdikhojayev, and my assistant is Abzal Jumabekov, and the second assistant Son U from Seoul, South Korea. Son U is a young colleague. He is planning to be neurospecialist in the future, neurosurgeon or neuroradiologist. Neurosurgeon, I think. And we have patient, young lady, just 51 years old. She previously bled. It was parenchymal and ventricular bleeding. And during the diagnostic algorithm, the brain AVM was found in left occipito-parietal territory. 4 sessions of embolization was done till now, and let's see the cast of liquid embolic. The AVM is more than 7 centimeter. It's a grade 5 AVM, and this is the arch bovine and both carotids, vertebral artery. And then Abzal made an angiography from the right side, from the brachiocephalic trunk and mostly the subclavian. The vertebral artery comes and then supplied to the AVM. This is the AVM, and it's supplying from the right side and the left side also. It might be collaterals, or it might be territory of thalamus and splenium of the corpus callosum. This looks like venous enlargement. Yes, it's more than 7 centimeters. If you count from here till here, it will be like 8 centimeters. Let's measure. Yes, and this is the Presidential Hospital, National Hospital of the Presidential Affairs Administration of the Republic of Kazakhstan, Almaty City, Kazakhstan country. Yes, it's like this, 7 centimeters. Kazakhstan country, and patient under general anesthesia. Surprisingly, usually the 70% of cases were performing under local anesthesia, and today we decided to do it under general because of the AVM and the long procedure. The meningeal supply is presented, and also the posterior meningeal is here. From the right side, it's coming like this and going up. The middle meningeal is quite tortuous in this segment, and this segment is quite straight. We can use this if it's necessary. And ACA territory is also supplied. This part is AVM. This part is also look like supplying this part of the AVM. It's still minimum 3-4 branches from the ACA. Yes, and then we have supply from the posterior circulation. Dural branches, and this territory. Yes, and also arch bovine, and it was a little bit tricky to catheterize the ECA and the ICA. This is posterior meningeal branch. We will check it. First of all, we will go to this posterior meningeal. We'll check the meningeal territory first from here. I think it comes something like this, and then supplying this part of the AVM, this part. It's quite distal from the draining vein, that's why we will go there. And maybe the thalamic part, in between, we will send for the gamma knife, those territory. This territory at approximately 3 centimeters. we can combine. And also the MCA has a 1, 2, 3, 4, 5, 6, 7, 8. There's a lot of branches, and here the passant branch. Yes, with this Spätzler Martin grade, I think it's a grade 6 AVM. MC aneurysm, IC aneurysm. This might be also the aneurysm. Okay, I asked Abzal not to do the 3D because of the clear situation with the branches and quite a big AVM, and it's a little bit expensive to go with the transvenous approach. That's why we'll plan to do it transarterially. This is a liquid embolic cast, and it's look like this. It's a vertebral artery. It goes from the back side, and this is the AVM. I want to ask Abzal if the patient has some visual problems. Yes, hemianopy. Yeah? Okay, hemianopy. Yes, it's usual things that occipital AVM after rupture and so big size, it should have some problem. I think the MCA territory is collateral supplying of these PCA branches, and to clarify the situation we should go to the MCA territory. But first of all, I want to go to the ECA territory because of some reason, and then we can check the MCA territory and the ACA also. Let's see the ACA territory from left. From left. It's not visible. To see the ACA, we should go to the right side because of the flow. The whole flow is going to the MCA, and we couldn't see the ACA territory. Anterior cerebral artery. And anterior cerebral is visible here. Yes, patient has ACA, but because of the flow, we couldn't see the clear situation. Pericallosal, callosal marginal artery is supplying the AVM. Okay, let's go to the left ECA, and then we will see what we can do. We took Merit Medical burn catheter, 125 with the hydrophilic wire, and then we have a short 8 French sheath, narrow max 90 centimeter. And I asked Zoya. Zoya is the operating nurse, and Nazem is a second nurse. For the Sonic 1.5 35, on the table we have fill 25%, liquid embolic, and also Sonic squid on the shaker. This system is zero gravity. I don't need an apron. I'm not wearing apron. I will use this one. Yes, as you know, we have large focus defects since October, and the tube is still alive and it's working. Till now it's alive, the tube. It's surprising. I was expecting the X-ray tube this and quite esoteric, but it's still alive. Okay, let's go with okay. Ровно. As the anesthesiology team is Жанна and Dimash. Dimash is not the Dimash Kudaibergen, it's a famous singer from Kazakhstan, Kudaibergen. Dimash is anesthesiologist, Dimash. And the anesthesiology nurse is Жанна. And video support today presented by Evgeny. Evgeny is our old friend since 2017. Yes, and for the friends who knows the situation with my father became stable. He's stable, and I transferred him from Karaganda city, which is 200 kilometers from Astana. And now he's in Presidential Hospital in Astana. After stroke, he has a dysphagia, some dizziness, and still in the bed. But yesterday he was discharged from the ICU, and it's good news. And now we are fighting with the pneumonia. It was look like the aspiration. It was the aspiration pneumonia, and now situation gets better. I hope he will do great with the pneumonia. Okay, now we are in the correct territory. From the occipital supply we will go to the posterior meningeal. Yes, it's like this. It's a sonic 1.5 by 35. Here is a bifurcation. Yes, and my father says hello and thank you for everyone supported with the praying, and thanks a lot my friends from NERADIC, from Discussion Narrow course. Yes, thank you. Your support was, I really feel your support. Thank you, friends. And the father is doing well. He's 89 this year, and he's doing great. Because of the walking, he used to walk 10 kilometers every day, and I think it was very helpful at the time of stroke. Okay. Okay. Yes, in this situation, better to send the microwire as much as distal to navigate the microcatheter. We should go to this branch, but the branch has a tortuosity and the wire is a little bit damaged. Yes, it's going to that territory. Okay, I postponed all my conferences till the monsoon meeting. I promised Uday to go, but yes, it will depend on the situation with my father. If he will do great and he will be stable, then I can join the monsoon meeting. I hope so. I can. Yes, it's better to go like this. Yes, now the wire is straightened, and then we can send the sonic distally. It says J-shaped hybrid 8. It comes in the box. This comes in the set of it looks like we were there with the liquid embolic. This is a custom liquid embolic here. Okay. It looked like we were here before, but it's still alive. That's why I think there are another branch. Just a second. Just a second, observe. Yes, and it was a slice meeting in the. I also couldn't travel to the 3C meeting in Jackson. Yes, it's really sad. It was very friendly atmosphere, and I have seen the photo archive from the Adnan Siddiqui Instagram and also from the Neradit. Yes, I really missed you, my friends. But I should stay with my father. That's why it's okay. Next year I can join you. Yes, there are another branch going to the AVM. I think we can use this. Should we go more selective? Or it's quite tortuous? It looks like quite tortuous. Yes, it's quite tortuous. We can use this, yes. Okay. We can go from here and occlude this part of the AVM. Fill. We'll do fill first technique and then we'll change to the squid. And also Roman and Abzal visited visited this Montpellier thanks to Vincent Costola and the friends. They said hello and I want to say you hello. In Montpellier they attended slice meeting the first days, and then on the 9th of July I presented our meningioma experience, and it was really interesting that we could push a little bit the question around the interest around the meningioma embolization and the vascular treatment after the publication of our experience in JNIS. People really interested in, maybe it will be some trial in meningioma, and we're using Squid 12. It's also possible to use particles as the Rahul Kumar is using. Rahul Kumar also in the paper. We joined several hospitals. Наркоз поглубже, дексаметазон. Уника. Okay. Yes, it's quite painful. Sonu. It's a painful procedure. That's why we asked for the dexamethasone. Dexamethasone to decrease the toxicity of the dimethyl sulfoxide, which is the main component of the liquid embolic system. And then we asked for the deep narcosis. It's very important. Yes, now the reflux is coming. Yes, on lateral we can see clearly the reflux, or it might be the penetration for the branch. Yes, we can use the fill. Yes, also a little bit reflux. Yes. Yes, for the skull base, it's very important the better visibility of the liquid embolic. Yes, it's quite long reflux. These two liquid embolics are different. The contrast in fill from the Tirumonero, it's iodine. It's modified iodine, and it's less visible, and then it causes less artifact. And in squid, also onyx, menox, lava, and different type of liquid embolics containing the tantalum. Tantalum is a metal. That's why we can see the cast of previously embolized part of the AVM. Okay. Yes, on slides I presented our experience from presidential system Almaty and Astana, and also a little bit about the paper. And now we're waiting the review and confirmation from the JNIS. Thanks to Edgar Samaniego. We wrote our experience on technical part, mostly focused on technical part, and I hope it will be published soon. The technical moments of the meningioma embolization. Okay, refluxing. In the microcatheter we have 3 markers: distal marker, the second marker, and third marker. It's safe to have a reflux of the liquid embolic till the second marker. On the second marker, the microcatheter is detaching like a lizard, yes, like a tail of the lizard. Sonic sureten көрсетші. Коробкасын көрсетші. Yes. The distal 3.5 centimeter in this microcatheter will be left inside the artery, and this part will be detached like a shuttle, yes, like a cosmic space machine. Because the reflux is creating the gluing of the microcatheter, and when you try to take it out, it may dissect the artery. It's for the safety. Rodlo. I'm pushing a little bit harder, but then we can see the reflux more. Yes, it's coming till the second marker. Okay, let's wait. It's a fill. We can wait. Yes, nowadays we have very limited number of cases monthly for the embolization and the intracranial aneurysm embolization. We have only 19 quotations. 19 patients could be treated in 1 month. Maksat, Abzal, Davlet is quite active, and they are doing more than 10 cases, and they're leaving me another 8-9 cases. I'm visiting this department for 2-3 days monthly. No need to stay for 1 month, yes, for the 9 cases. Before we used to do 100 cases monthly, and then the insurance system is cut the budget. Yes, and now I should work in Astana Presidential. I'm treating the patients there also. They have 4 cath labs, and also working in an oncology center in Astana. They have some quotation, that's why we can treat patients there also. And twice a month I'm visiting Uzbekistan, Tashkent city, and with the team of Tashkent specialists we are doing 10 to 15 cases monthly in Tashkent. And altogether I'm doing approximately 40 cases monthly. Yes, it's okay. But before I used to do 70 to 100 cases monthly in this department. Yes. Then I can teach my young colleagues how to work with the instruments and how to deal with such kind of complex patients. And also in Tashkent, it's possible to treat the pediatric patients. In Kazakhstan, through the insurance system, it's possible to treat the pediatric patients only in Astana Presidential. But the private patients we can treat in private hospital in Almaty. I have my young fellow and colleague, Nurjan Suleymankulov. He's working there. We opened the Department of Neurosurgery in 2020, I think it was 22. And they bought the Siemens Icono monoplane machine, and it's possible to do complex cases there. And for the private patients, we are working there, not here. And pediatric patients, they have pediatric license, and we can do children embolization, children treatment for the private in that hospital. It's very important. Only one hospital for whole Kazakhstan is quite bad. It's a 20 million population. It should be approximately 5 or 6 centers doing this treatment for the pediatric. Okay, we are taking the collaterals. Okay, this could be the collaterals from dura, and also it could be supply from the vertebral artery. We should check the pica territory. That's why I'm trying not progress to the brainstem territory. It might be something like this. Huh? This territory could be supplying the AVM. That's why it's safe to stop here. Yes, it's very complex to deal with the AVM, supplying from everywhere. Okay. This one could be this one, this one. You see? Yes. That's why this point is quite safer. If we will go till here, then we will occlude both branches. Okay. It's a pica, it's a cerebellum hemisphere. It might be small ischemic change, but usually in AVM cases the patient has a nice collateral supply. We'll see. I hope it will not go there. It will go up. Okay, now it's better. We can little bit press more. Yes, it's quite safe territory. Yes, now we are progressing. The difference of the fill can occlude the venous part, and then it's solidifying and increasing in volume. That's why it might be disadvantage of this liquid embolic. The advantage is there is no metal artifact, and the penetration ability of this liquid embolic is quite nice. That's why we have a different type of liquid embolics for the different reason. It's very important to have different tools. It's a quite complex disease, and it couldn't be treated even with one modality. Yes? Пациент просыпается. Patient is moving. Yes. Пациент просыпается, наркоз глубокий деп айттым ғой. Басын қимылдатты. Тура қойыңыздаршы басын. Мы же наркоз попросили, ребята. Ай, блин. Okay. Okay, patient is moving. We can call it general anesthesia. Yes. Кастратор. Наркоз берсін, сосын дұрыстайсың. Наркоз берсін, сосын дұрыстайсың. Because of the dural supply from the posterior meningeal, the dura is painful. If you work through the brain is not feeling the pain, but dura is very sensible. That's why when you inject more, then patient can feel if there is no general anesthesia. Yeah? Тура koyasın. Jo, turmadı. Okay, let's check how it was before. Kaz bir sekund. Yes. Normal. Все, kaldırasan. It's very important because of the liquid embolic may change the way of penetration and the case treatable from the beginning. It might be non-treatable at the end. Okay. Now we have reflux. Not bad, not good. Okay. Okay. Thank you, my colleagues. Let's change for the squid. Анан лактырасың. Орнына squid жинайсың. Yes, the good penetration, we could progress distally, and before the injecting liquid embolic, I asked my colleague to give the deeper narcosis. Yes, I don't know. I think it's everywhere. When you work with the team and you have no dedicated team for the neuroanesthesiology, it's everywhere. I think all my colleagues from abroad are living in this condition. When the team is not team, they're just working for the salary. Okay. Now we'll have progressive reflux, and then okay, maybe it will go forward. Let's see. But at this moment, the artery may rupture. We should keep in mind. It's progressing. It's progressing. It's going up. I think this part is ruptured, huh?
Yes, it seems like.
It seems like it's ruptured, and also we have a reflux. Thank you, my colleagues. A very nice supply became. Okay, we reached the AVM territory. It's not bad. Пока, Piotr. Okay, let's check what changed. Also, there are the meningeal supply from the middle meningeal. Yes, we have another part of the supply. Okay, we can go to that branch. Now it's more clear. But it's quite distal, and it goes. It's quite distal. This supply is quite distal. Okay, maybe we can check it. How it's look like. But it's very close to the pyramid. It's a pyramid. And if you inject it above the pyramid, it could be supplied to the facial nerve. We have another branch from the right side. Also the middle meningeal supply from the right side. And there are MC branches also. Okay. There are MC branches going here and supplying this part. This part, this part, this part, this part, and also AC branches. Okay. This branch is going here and then going like this. Okay, let's take one more sonic. Тағы бір соник алдырасың. Бірді бес, отыз бес. I think this is... we can use this, yes. Тек гибрид ашсаң болады. Тек гибрид ашсаң болады. Сол жеткілікті. Бірді бес, отыз бес. Гибридін ашпайық. Okay, let's use this one. Okay, let's check it. How much is close to the brain, to the pyramid. Хотя ашсаш гибриді. Гибридін ашсаң. Басталып кетеді. Time to time we speak Kazakh. It's not Russian language, it's Kazakh language. Between the team, we speak Kazakh. It's a Turkish family of languages. And it's my native language, the Kazakh. It's like Korean language and English. The difference, yes. Так, ана ДМ жинап қоя сал тағы бір. ДМ жинамай қой, тағы бір фил ашып бере салшы. Бір фил ашып тастай сал. Okay, let's start with the fill. And then we can change for the... Yeah, fill ашып тастай бер. Столға аласасын абзал. Okay. Арғы стол қаласы сәпік. Арғы стол қаласы. Әлі 2 сағат жұмыс істейміз, наркозды расчет жасаңыздаршы. Оянып кетпесін. It's a real life scenario when the patient is becoming awake during the general anesthesia. It's everywhere. I am treating patients in Central Asian countries, also we did the cases in India, in China together, in Macedonia, in Turkey, and it might happen everywhere. Тогда нам... бір секунд. Окей. Сделаю. Smart mask. Glue dalpsa, smart mask. Navigate pressel. Navigate. Smart mask. Okay. There are spasm on the artery. It's okay. Okay. Now it's a little bit safer. Can go distally. Yes. It doesn't want to go. Okay, now it's going. Yes, yes. For this reason, I think the Scepter Mini micro catheter is better option. Huh? It could work better. Okay, let's do Andrew from here. Microcatheter is detached. We have problem with the second marker. Yes, the liquid embolic comes, the contrast comes at this point of second marker. Вперед, вперед, назад, вперед, назад. And it's also supplying the posterior part of pyramid. Huh? Okay, I think no need to touch this part. Okay, the microcatheter is broken. Yes, it's like this. It's ruptured here. Not at the marker, it's ruptured a little bit distal to the marker. Usually it detach at the marker. Okay. Okay, let's keep it. Maybe we'll send to the company just to check for the manufacturing problems. Так. Sonic бірде бес 35 берсе шкафтың ішінде бар. Okay, maybe we'll go to the right side, and through the middle meningeal we can take part of the AVM. I don't want to go through the MCA territory because we need more material. 2 microcatheter, the second microcatheter should be the headway duo. That's why I think the better is to finish here. Aşağı salaşsın. Okay. That's okay. We took some part. The meningeal here is okay, but we should go with the traxis and scepter, which is not available for this case. That's why I prefer to go through the right side. Right, I see. Біздің физрастарымыз бітейінде отыр деймін. Ауыстыра салайықшы пока кірмей тұрып. Екінші системаны бере сал. Алып сай сал. Коннектор алып сай сал. Бұрай көр. Okay, no problem, I will do it like this. Yes, the Abzal in the morning had a very nice porridge. He put the Y connector in a very strong position. Yes, when the colleague has a breakfast, then it might be sometimes problem, huh? Okay. I hope in English there is also the jokes like this, yeah? About Родно? Еще раз. Okay, now we will go through the middle meningeal. In this part, patient also has a posterior meningeal artery. Okay, let's go here. It's a maxillary artery. Okay. All right. As the diameter of the microcatheter is 1.5 French, and the diameter of the wire is 0.08 inch. Was it? It's a US metrics. Huh? It's old metrics. It's not millimeter. Okay. Maybe we will do the consultation in the department of Gamma Knife in Astana. For the choroidal part of the AVM. Okay. It's a middle meningeal artery. It's very important artery in the body, the middle meningeal. Nowadays the chronic subdural hematoma is treating through this small tiny artery. The name is middle meningeal. And also the modern treatment of the migraine, also possible through the middle meningeal artery. And we are treating the meningioma patients through the middle meningeal, in most of the cases. Yes, okay, let's check. Yes, this artery. We will use this one. This one is this one. It goes here. And all these meningeal arteries are going to one point, usually. I think it's that branch. Yes, in most of the cases, the chronic process, you can see the artery on the bone. And yes, in this case might be we already used this artery. And let's check. Huh? Okay. This looks like we already have been there. We need to use the lower branch. Okay. Стоп. Вперед. Назад. Стоп. Назад. Вперед. Вперед. Smart mask. Okay. We created some spasm. That's why the branch going up. It's not visible. Now I will try to catheterize it. Yes, this one. It was look like it's interrupted, but the branch is there. Okay, let's check with angiography. Yes, there is nice territory, but it's supplying directly to the vein. Huh? It's supplying directly to the vein. Smart mask? Ага. Хорошо, проводник идет. Let's check. I'm doing small curve. The background voice is a Surah Bakara. Yes, Bakara. And yes, you could be very experienced, but as I know, most of the surgeons are theists. They believe to God, and that's why they can use Bible. They can pray during the operation, and we start to use Surah Bakara more than 2 years ago, and it's very helpful. And it's not annoying, yes? I'm trying to use the Surabakara in all cases, almost all cases. And I found it very helpful. It's very helpful for the patient and it's very helpful for the team. And patient could be the Christian, the other religions, and usually it's helpful for all patients. Yes, if it helps to the patient, we can use it. Eh? It's very important. If it's very helpful, we also use the drugs, narcotics, marijuana also could be used for the treatment. If it's helpful. It's not comparing with marijuana, but in medicine we use the poisons as a chemotherapy. It's very toxic, the most of the medications, but if it's really helpful to the patient, why not to use? Okay, it might be a little bit dangerous. It's very close to the draining vein. Okay, let's try to do it as much as safe. This would be the point of safety. The point of safety could be this one. Okay. Наркоз глубже. Наркоз глубже. Yes. Because of the previous experience, I asked general anesthesia before the injection. Okay. Так, алдындағы сквит бар ғой? Сквит бар. Иә, соны бері сал. Жинап қой сол. Так, коробкамен кім барып жүр қазір? Бухгалтерияға коробкамен кім барып жүр? Коробкалар жинап. Мақсатгевич барып жүр ме екен? Иә, Мақсатгевич бар. Ана, қам инструменттерді жинап алып барыңдар. Я бәрін жинап апарасыңдар ғой, ана пакетке салып, Y коннектор, шприц бәрін жинап апарыңдар. Может, сендер шприц ұтып алып жатқан шығарсыңдар деп айтады ғой, да? Okay, now the liquid embolic could go to the vein. Yes, start to occlude the vein. Oh, it's arterial supply. Ана, последний ангиографию қойсаш. Супер селективно. Сон қойсам. Вперед. Стоп. Yes, it's a safe part. Smart mask. Родно. Yes, it's just the beginning of the vein. It's a primary vein, that's why it's quite safe position. It's better to have a reflux here and to occlude the other part of the AVM. Yes. Yes, in this part we have a lot of supply from the MCA. We can occlude the supplying territory. This look like vein, huh? This look like vein. And in this position the angiography is not helpful because the supplying territory from the posterior and the MCA territory. Yes, all those are arterial supply. I think it's artery. But it might be vein, huh? Okay, let's wait. Средний мозговой жақты қарайсаш, осындай структура болды ма? Осыны көресіз, пока осыны көресіз. There, venal. Yeah, venal. It's a vein. It's the beginning of the vein. For us, very important to close the collaterals and not to penetrate the venous part. It's very important. If we can occlude the arterial supply, then it's better. Is it artery or vein? Now it might be vein, yeah? Родма. Пока сол жақтағы среднемозговой қарап қоясаш. Yes, maybe in this situation the use of the AI, artificial intelligence, could be helpful to identify the venous part, identify the arterial part, to mark the safety margin of the treatment. Huh? Yes, this looks like vein. Maybe in the future it will be available some medication, just take a pills and it will work. Huh? What's this? What's this? It's moved from this part.
Then it was the vein.
It might be the vein. Yes, it might be the migration of the liquid embolic. This is the vein, yes, it's a vein. Yeah. Okay. Maybe we're close to the point of finish, yeah? Maybe. Let's see. Let's see one more time. Rodno. Okay, now it's going back, it's very nice. We should include the back part. Then it's a collateral, huh? like it's arterial collaterals. Так, теперь секунд. Ровно. Yes, for the cases like this, the obtural liquid embolic might be preferable because of several sessions, and now we don't see it exactly where the liquid embolics is going. This is collaterals, it's meningeal collaterals. Yes. This part looks like it might be the beginning of the vein, yeah? As it's becoming larger. If we see this picture, it looks like the vein goes like this. Okay, it's okay. Пока динамотр. The middle meningeal artery like a seal. Million of roads going collateral and then going to the highway. It's like this. You go just from the village road and then you can enter to the seal. Eh? It's like this. Okay, let's see. Yes, it's around the draining vein. This might be the draining vein. It's the beginning of the vein. Okay, let's wait. Let's wait. Let's analyze. That's something here. Might be this one. Yes, it's this territory. This territory. It's somewhere here. Yes, the vein is going up and going like this. Going up and then going here. Okay. In the interventional neuroradiology, the brain AVM, I think the most complex pathology. Yes, the aneurysm is also complex, but the treatment modality, yes, it's most of the time congenital, that's why it's quite complex to treat those patients. It was several attempts through the dural supply and also from the posterior circulation, ACA territory. And now from the Spain it was developed new embolic agent. It's like a fill, the visibility is the same, and then in a couple of months the contrast is disappearing. The liquid embolic is staying there, it's solidifying, and then the contrast is disappearing, and the second session, next session, is very comfortable. There is no artifacts. No metal, yes, it's free. I think now it will be the next step in endovascular treatment of the brain AVM. Complex AVMs. If it's a grade 1, less than 3 centimeter, no difference. Is there tantalum or not? But for the AVM more than 3 centimeter, it's very important. If the second session is more like a first session, it's very good. Huh? This looks like a vein. Okay. Let's wait a little bit. Maybe we can finish at this stage. We'll see. It's very close to the venous part. It's a direct shunt, artery-venous shunt. That's why the risk of venous occlusion is higher than if you go through the artery, then the compartment, it's arterial to venular, and then the primary vein. It's more safer. But in this situation, the shunt is direct from artery to vein. Hello, hello. Okay. Bir жарым болды ғой. Okay. There is an agreement memorandum with the university, yes? SONU.
Me?
With the Almaty University, yes? It's an exchange program.
Yeah, I'm
Yes.
Karmu. For Karmu.
Karmu. Karaganda. Through the Karaganda University, yes?
No.
Krmu.
Kazakh-Russian.
Kazakh-Russian Medical University. It's very nice. Marat Sarshayev is teacher in Karmu.
Oh.
He's teaching neurosurgery. He has a lot of students. Huh? Okay, I think this is a point of finish. Yes. In this case, because of the very short reflux, the tip is not detached. It's not detached, but usually it happens like this. Regularly. You have a reflux till here, or maybe here. When you try to remove it, it detaches like this, and this part is staying there. It's approximately 90 gram. 90 gram of force, yes. Okay. No, also. Нені бері сал? Пятерканы бері сал. Пятерканы бері сал. Шынақ. Катетр бар ғой? Бәрін катетр бар ғой жаңа? Соны бері сал. Okay, we should check the old circulation. Now we will do the control angio and then we can finish the case. We have limits, yes. It's a material limit, it's a radiation limit, it's a contrast limit. Okay, there's another branches from the middle meningeal. Okay, it's still supplying. Okay, there is another 2 branches. 2-3 branches going there. As the posterior meningeal is not so active, and we decrease the flow in the draining vein. Huh? If the CT is normal, we can give some heparin. Because slow flow may create the thrombus inside the vein. Okay, we will check the CT and then we can give 3000 units of heparin. And it's also possible to keep on heparin for heparin for 1 day, and then we can switch for the low molecular for another 5-6 days. Yes, when you occlude the big fistula, then the AVM became less active. Okay. That's nice, yeah? Okay, let's check from here. The important part is venous. Yes, we slow down the venous system. Now it might be a little bit dangerous, huh? Yes, the vein is big enough, but the slowdown in the venous system is not good, huh? It's not safe enough. It's a vertebral artery. Okay. Got this. That's okay. It's just the slowdown of the draining vein. Okay, I will take ready. Now we will do the expert CT. It's a CT. Expert CT. It's okay. Okay, let's wait. Now will be the CT, computer tomography. You can see how he will do. Items. Dear colleagues, the expert CT is ready. Okay, let's see it on Instagram. NPR. Okay. Let's work with the contrast. Like this. The important part is the ventricles. If something will happen, might happen, then the ventricles will change first. And the ventricles are in place. The brain is in place. Yes, the posterior fossa is clear. This part a lot of artifacts, but it's okay. And then draining vein and the brain, it looks normal. Now we will ask from anesthesiology team to give a 3000 unit of heparin and then 500 units per hour for till tomorrow. Казар шумын гепарин внутриленно, потом 500 гепарин в час до утра. We will keep the patient in the ICU till tomorrow. 500 в час. Okay, because of the slow flow in the vein, we have a slow flow in the venous part. And then it goes to the vein, and this part of the vein is stagnating. It might be thrombosis, that's why it's better to keep patient on the heparin for 1 day, and then we will switch for the low molecular Clexan and oxaparin. Okay. Okay, thank you. Now we can finish the case and see you in next 30 minutes. Next case is aneurysm, IC or MCA, we will see. Hope to see you in 30 minutes. Thank you for watching. Bye bye.